So I'm going to talk about triglycerides from vital to reduce it. I have no financial disclosures, but I do have to disclose on occasion I will eat a hamburger and French fries that raise my triglycerides. So triglycerides, is there an association between elevated triglycerides and cardiovascular disease? I can remember when I first started practicing, I had patients with hypertriglyceridemia, and everyone said, well, we don't worry about triglycerides. They're no big deal, and now they're an independent risk factor. So the more we study it, the more we learn from it, just like anything else. And we know that LDL alone does not fully reflect the circulating burden of atherogenic lipoproteins, which is why many of us in lipid clinics and in the cardiovascular world also use non-HDL as a surrogate marker, or maybe ApoB. So we do know the triglyceride risk is different between male and female. So for each 1 millimole per liter increase in triglyceride associates with a 32% increased risk in men and a 76% increased risk in women. So it has greater impact in the female population. And we know from our statin trials that elevated triglyceride levels are associated with higher cardiovascular risk. So the big thing in hypertriglyceridemia is assessing your secondary causes. I can't tell you how many times I get referrals from primary care physicians for hypertriglyceridemia. I check a hemoglobin A1C on them, it's 12.3. So you're not going to fix triglycerides until we fix the underlying problem. So this is essentially looking at a lot of your secondary disorders. And what we often sometimes forget are the very drugs that we put them on to treat their hypertension, to treat other disorders, their tamoxifen, their oral estrogens. And these oftentimes are the main reason that our patients have hypertriglyceridemia. Of course, I practice in the South, and this may be one of the reasons in the South that our patients have hypertriglyceridemia. So this is what essentially all of us have known, the classifications of triglyceride levels. And this goes back to ATP3. In the 2018 guidelines, they've condensed it down from these normal, borderline, high, very high. They condensed it down to essentially two subsets. So you have moderate hypertriglyceridemia with a fasting or non-fasting triglyceride, 150 to 499. And you have your severe hypertriglyceridemia patients, which is classified as greater than 500. So your moderate really are looking at your VLDL and LDL, and your predominant goal is to reduce your ASCVD risk and reduce your VLDL. Unfortunately, and we'll talk about this again in just a minute, we don't have any evidence-based therapies up until now that have targeted triglycerides and reduced our cardiovascular risk. For your severe hypertriglyceridemia patients greater than 500, you're really looking at the elevated VLDL and chylomicrons. And in this patient population, our predominant concern is pancreatitis, and you're trying to avoid patients going to the ER with acute abdominal pain and pancreatitis. So we address your secondary risk factors, and predominantly the 2018 guidelines recommend statin therapy, but also going on a very low-fat diet, avoiding the refined carbohydrates, alcohol intake decreasing, omega-3 fatty acids, fibrates, and even niacin sometimes can be used in this patient population. However, us as providers are terrible at recommending diet to our patients. We do very well at telling them they need to follow a diet and they need to lose weight, but we're terrible at telling them how to do it. So what I liked about the European guidelines, the 2016 guidelines, really talks to patients a little bit more as to what they need to manage in their dietary intake. And for any of you that work in cardiology or in a lipid type clinic, certainly having access to a dietitian is beneficial for your patient population, so they can really get into how patients need to manage their dietary intake with hypertriglyceridemia. So pharmacological approach, certainly we talked earlier about statins to reduce your cardiovascular risk. Statin therapy is your primary choice for a pharma agent. Fibrates are still used to avoid pancreatitis, but currently, we do not have any cardiovascular outcomes in the fibrate management. People forget about bile acid sequestrants. These are used to lower LDL. However, your bile acid sequestrants do raise your triglycerides. So a lot of times patients come to me with hypertriglyceridemia and they're on bile acid sequestrants for their LDL because they're statin intolerant. And the first thing I have to do is take them off of that in order to assess what their triglycerides really are. Omega-3 fish oils, and we're going to talk about this more in just a minute. Your prescription omega-3 fish oil, 2 to 4 grams, should be used to treat your severe hypertriglyceridemia. And we need to remember that dietary supplements are not FDA approved for the treatment of hypertriglyceridemia, and they're not studied, so shouldn't really be recommended for our patient population. PCSK9 inhibitors are utilized predominantly for lowering LDL. However, if you are treating a patient for their LDL and they do qualify and meet criteria for PCSK9 inhibitors, you usually get about a 20% reduction in triglycerides with those PCSK9 inhibitors. Your cholesterol absorption inhibitors are predominantly for LDL. And poor niacin. In the literature, we've seen multiple times no cardiovascular outcomes, but to avoid pancreatitis, it can be used to lower triglyceride levels. Let's talk a little bit about omega-3 fatty acids. A meta-analysis of 78,000 patients published in JAMA Cardiology in 2018 showed no reduction in cardiovascular events with omega-3 fatty acids when compared to placebo. This brings us to the VITAL study, which looks at vitamin D and omega-3 fatty acids. The purpose was a primary prevention role of the daily supplements of vitamin D or omega-3 fatty acids in reducing the risk of developing cancer, heart disease, and stroke in people with no cancer, heart disease, or stroke to begin with. Over 25,000 patients, 2x2 design with high-dose vitamin D3, 2,000 IUs, omega-3 fatty acids, EPA and DHA, 1 gram daily. There was a vitamin D and omega-3 placebo arm, a vitamin D placebo and omega-3 fatty acid arm, and both placebo arm. And this is essentially what you see. Major cardiovascular events and total invasive cancer were not significantly reduced by the omega-3 or the vitamin D3. However, omega-3 significantly reduced the total MI, and this was driven by the African American population, as you can see with a 77% reduction. So this then leads us to the Reduce It trial, looking at icosapent ethyl on total ischemic events. And the purpose of this study was to evaluate whether icosapent ethyl combined with statin therapy will be superior to the statin alone when used as a prevention in reducing long-term cardiovascular events in high-risk patients with mixed dyslipidemia. So this is the design of Reduce It. Over 8,000 patients were randomized with icosapent ethyl 4 grams daily versus placebo. Follow-up mean 4.9 years. You can see over here to the right, your patient populations, both a primary prevention cohort and a secondary prevention cohort. What I like about this is that your fasting triglycerides were greater than 135 to less than 500. Your LDLs were greater than 40 milligrams per deciliter, but equal to or less than 100. And patients were stabilized on statin therapy plus or minus ezetimibe. You can see your primary and secondary endpoints listed below. And this is essentially what we found. You can clearly see a 24.8% relative risk reduction with an absolute risk reduction of 4.8% in your primary endpoint of cardiovascular death, MI, stroke, coronary revascularization, and unstable angina. The key secondary endpoint, you clearly see a relative risk reduction of 26.5% with an absolute risk reduction of 3.6% in cardiovascular death, MI, and stroke. This is essentially your hazard plots. As you can see, the icosapent ethyl is clearly better in all of the primary and key secondary composites. The baseline characteristics, what I like about this is these patients are the patients that we see every single day. This is very relevant to our current practice. You can see the median LDL is here in the mid-70s, so technically not at their threshold goal by the 2018 guidelines. And you can look at the different tertiles of the triglycerides, and these are the triglycerides that we see on a fairly common basis in our cardiovascular practice. Once again, this is looking at first and subsequent events with your icosapent ethyl versus your placebo arm. And this is evaluating your hazard plot ratios based on tertiles for your triglycerides. So you see here clearly your icosapent ethyl arm was much better than the placebo. So compared with placebo, the icosapent ethyl 4 grams daily significantly reduced total cardiovascular events by 30%. So 25% in the first cardiovascular events, 32% in the second cardiovascular events, 31% in the third cardiovascular events, 48% reduction in the fourth or more cardiovascular events. So I don't have a top 10 for this talk. I just like to say that my top 10 commandment is only one commandment. For the first time ever, we actually have a triglyceride lowering medication that has cardiovascular outcomes, and that is approved. Currently, Amarin has gone to the FDA for a change in their PI, because right now you can only prescribe and get icosapent ethyl if you have triglycerides over 500. So they're applying to the FDA to add their cardiovascular outcomes and change the range from 139 to 499 and greater for our patient population, which hopefully will make it a little bit easier for all of us to get it approved for our patient population. Thank you.